Welcome, everybody. On behalf of JDRF, I'd like to welcome you to our Let's Talk T1D educational series. Our speaker tonight, Dr. Alana Halperin, will have about 30 minutes to 40 minutes to talk about reproductive health in T1D. We hope to have about 15 minutes afterwards for questions and answers. This is your first time. Thank you for coming. JDRF is a global leader working towards an end to type 1 diabetes through research, funding, and advocacy. JDRF also supports people and families in the T1D community in the time of diagnosis to help by helping those living with T1D have better, healthier, and safer lives while we work to find a cure. As visitors on this land, I would like to begin by respectfully acknowledging that the JDRF Canada National Support Office is located on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Our education series offers information on a new topic about every month or every other month. Our next section will be September 18th on disordered eating and type 1 diabetes. We also host a virtual connection series on the fourth Wednesday of each month. This is an unstructured opportunity to connect with others with no formal programming. And the next one will be August 28th and September 25th. And if I could just remind you to please mute yourself so that we can eliminate some of that
I
background.
saw he was in his office at lunchtime.
Hey. And again, if you could just keep yourself muted and put any questions you might have in the chat, and we'll do our best to get to them all at the end. But just a reminder, we can't answer really any personal health questions. That's something to take up with your endocrinologist or general practitioner. And so now I'd like to turn it over to our speaker. Dr. Alana Halperin is an endocrinologist and Chief Medical Information Officer at Sunnybrook Hospital and the University of Toronto. She has a large type 1 diabetes practice with a special interest in young adults and pregnant women and has been recognized as a Canadian national expert in the application of diabetes technologies into virtual care. She is a strong advocate for the use of advanced technologies to help people living with diabetes decrease the burden of this complex chronic condition. She has led the publication of a Diabetes Canada position paper on the use of DIY automated insulin delivery technologies and is currently co-leading a Diabetes Canada guideline on glycemic management in T1D across the lifespan. We are so grateful for her giving us her Thursday night tonight. And with that, I will turn it over to you, Alana.
Okay, thanks so much. Can everyone, can you hear me okay, Ruth? And it's projecting all right?
Yeah, we can hear you.
Okay, great. All right, so let's get started. So here are my disclosures. As Ruth alluded to, I do some work with a bunch of different diabetes technology companies. I won't really be giving any specific recommendations today, but I'll certainly be talking about anything that is off-label. So we're going to talk about three specific periods of time in a woman's life that can impact their glycemic management. The first is the menstrual cycle, the second is pregnancy, and the third is perimenopause and menopause. I opted not to talk about puberty because I am not a pediatric endocrinologist. So, first we'll start with menstruation, and just like this little meme here, because diabetes is hard enough. And then when you add in all of the hormonal fluctuations that people with uteruses experience, it's a lot. So let's dive into a case. The picture is stock footage, but the case is a real patient of mine who's been struggling with unpredictable glucoses for many years, started real-time CGM 2 years ago, and started to notice a specific pattern. High glucose for a week, she'd increase her insulin, then she'd have low glucose for a week, so she'd have to decrease her insulin, then it would be stable for a while, and she felt like she was really going crazy. But then she started on Control-IQ technology, which is one of the automated insulin delivery systems available with Dexcom and the T-Slim. And so we're going to see what happens. So just a quick look first at the menstrual cycle, just to level set for folks who may not remember grade 11 biology. The cycle can be divided into two main areas. The first being the follicular phase, where a follicle is maturing, but prior to ovulation. And the second is luteal phase. After the follicle, the egg has actually been released, and it's called the luteal phase. And during that time, progesterone is the dominant hormone. And if after 28 days there's no sperm to meet a follicle, then the corpus luteum, which is making the progesterone, dies off and the progesterone levels drop and bleeding ensues. And so a lot of people experience quite a difference in their insulin sensitivity across these different phases of the menstrual cycle. And so this is a glucose report from my patient looking at her glucose control between her follicular and her luteal phase. So each is a 2-week time period, and it doesn't project great, but the bottom line is the glucose results in terms of her time in range, her time below range, her coefficient of variation, they're all pretty similar. But what's quite remarkable is how much difference the pump is giving her in terms of insulin in order to maintain that. So she gets on average 15 units more of insulin a day in order to maintain a similar glucose pattern between her follicular, which is the estrogen dominant phase, and her luteal phase. And so you can imagine why she felt like she was going crazy before she had automation, because she was having to make that type of insulin adjustments herself. So there is some evidence to suggest that across the menstrual cycle, time in range does drop, with the highest risk for time below range and higher risk of variability that's swinging from high to low during the mid-follicular phase just before ovulation. And so insulin adjustments are often required in the luteal phase to maintain glucose management. But when people aren't on sort of dynamic or automated insulin delivery, then when the period comes, if the insulin doses aren't reduced back down, then there can be a high risk for hypoglycemia. And certainly, as I've already alluded to, it seems that insulin sensitivity decreases after ovulation in most ovulating adults, but not in all. And when we say insulin sensitivity decreases, that's the same thing as saying insulin resistance increases. So what does that look like for you? Well, if you don't increase your insulin, then you're going to have higher glucose values. But not everyone who menstruates has the same pattern. And it's an interesting study here that shows that the group that had the larger time in range decrease were already the group that was struggling to meet our time in range targets to begin with, had higher variability and higher percentage of those try to adjust their insulin. They also had a longer time of diabetes, which may suggest that perhaps they just had more of a like less endogenous pancreas function, and perhaps the groups that had diabetes for less of a long time still had a little bit of pancreas function of their own, and just where diabetes management was just sort of easier for them, so they didn't notice as much of a difference after ovulation. But what we can conclude from this phase is that overall automated insulin delivery has certainly helped this patient. And to make things even more adaptable for her, we could consider different pump profiles between the different phases of the cycle. And so depending on what type of insulin management you or your family members use, knowing the fact that insulin sensitivity or insulin resistance changes quite a bit across the menstrual cycle, just having that knowledge, I think, is powerful, because often when I say to my patients, oh, it's probably because of your period, they're like, no one's ever mentioned that to me before. But knowing that fluctuations in your hormones across the month is going to require different amounts of insulin can be quite helpful. So now we'll go to another case, Annie, who's had type 1 diabetes for the majority of her life and is trying hard to meet preconception pregnancy targets. She's thinking about starting a family, and so she Googles, can I have a healthy pregnancy with diabetes, and gets a lot of challenges and fears and just concerns about the risks of diabetes in pregnancy. And, you know, some of you, depending on where you're at in your life stage, may have been told that you could never get pregnant, or that having a pregnancy with type 1 diabetes was a bad idea. So I'm here to show you some data today to remind you that it is certainly not the case anymore. And I'm highly supportive of patients with type 1 diabetes planning families, but it, just like everything with diabetes, it needs to be planned. So we'll talk a little bit about that. So why do people say it's a bad idea? Well, you know, there are a lot of risks. So we know there's an increased risk for high blood pressure, or a condition called preeclampsia. Increased risk, high blood sugars early in the first trimester can increase the risk for fetal malformations, the baby's organs not forming properly. The babies tend to grow bigger and make more insulin themselves. So they have a risk of low blood sugars after delivery, which can result in admissions to the NICU. Moms tend to be more likely to have cesarean sections because of the size of the babies and the difficulty with delivery. And there's an increased risk for stillbirth and perinatal mortality and macrosomia, which is the medical term that describes when the baby gets too big and there's difficulties coming out. But though all of these complications are tightly related to glycemic management. Oops, I won't advance here. So we know that optimal glucose control during pregnancy reduces the risk of maternal and neonatal complications, but only 15% of women can actually achieve guideline recommended glucose control. And that can make people feel really quite anxious, right? Every time you see a high number, you think that you're causing harm to your baby. And now that I've been working in this area for over 10 years, I can say confidently that it is certainly not one high number is going to harm your baby, and it's certainly glucose exposure over time. And most of my patients with type 1 diabetes still have big babies, and a good number of them have to go to the NICU. But ultimately, they can have healthy offspring that can grow up to bring joy to the people around them, and that super hard work of managing diabetes in pregnancy is still worthwhile in the end. But we know that preconception care is really critically important. So that's what I was alluding to before about the importance of planning and working with your diabetes team if you're thinking about a pregnancy, ensuring things are as optimal as possible. And oftentimes that means getting on more optimal technology. So the time and range targets in pregnancy are different. And so most of you would be familiar at this point with the time and range target of 3.9 to 10 for most people. And in pregnancy, it's actually 3.5 to 7.8. And so you can take the exact same Dexcom Clarity ambulatory glucose profile and apply a different time and range target, and it can feel really defeating. But we know that using CGM in pregnancy is actually critically important. This was a really important trial that came out over almost 10 years ago now. It started 10 years ago. It came out, I guess, 5 years ago now. And I was one of the site investigators. The lead investigator was my colleague, Denise Fage at Mount Sinai. And this was actually one of the first studies to show that CGM isn't just a monitoring device. It's basically an intervention because it had really significant impacts on maternal and neonatal outcomes. So women were randomized to wear a blinded CGM so we could get some CGM data versus use CGM in practice. And I can tell you, because I was one of the site investigators, this was long before we had the CGMs of today. Women who weren't on insulin pumps were carrying insulin pumps around in their purse as the receiver for their CGM. There was no approach to an ambulatory glucose profile. We really didn't know as physicians how to coach patients on how best to use the CGM. So really the data that was gleaned from the CGM in this trial was insights that were kind of in the moment, real-time insights that the moms had. And what we found at the end of the trial was that for about a 7% increase in the time and range of that tight pregnancy time and range, there was a significant decrease in the number of babies born large for gestational age, needing to go to the ICU or having significant hypoglycemia. And what an NNT means is it means how many people needed to get a CGM to prevent one bad outcome from happening. So the lower it means it's a more cost effective or just effective overall intervention. And so those NNTs of 6 and 8 are really profound. And actually, because of data from Concept, both Australia and the UK provide CGM for all pregnant women. A lot of them have moved beyond CGM, just pregnancy, to all people with type 1. But before there was universal coverage, they were providing universal coverage to pregnant women with type 1 to have CGM because of this trial. And so now we have, good Diabetes Canada recommendations that CGM should be used across pregnancy to improve glycemic management, which has a direct impact on the neonatal outcomes. It's like, as I mentioned before, quite a challenging target to achieve. And, like with any of my patients, if you're starting at 40%, we're not going to get to 70% overnight, but every, 5% increase in that time in range has a significant improvement in terms of the risk of neonatal complications. So wherever we can have more green, less yellow, and less red is our goal. But now we've got growing use for automated insulin delivery in pregnancy as well. And this pretty new trial that just came out in the fall of this past year, 2023, from the UK, randomized women to use an automated insulin delivery system that's not yet available in Canada, but will be soon, called the CAM-APS. It stands for Cambridge Artificial Pancreas System. And the CAM-APS system is great because it has a modifiable glucose target, and targeting lower glucose levels in pregnancy is really critical. And so what they found in the trial was that the women who were using the CGM were able to achieve about 10.5% more time in the target time and range. And that was particularly obvious overnight. And for any of you who already use automated insulin delivery, you'll appreciate how useful the algorithm is overnight. And you can see especially that there was a difference in the groups who were on the closed loop system compared to the standard of care as we move through the more difficult parts of the pregnancy. Between sort of 24 and 32 weeks is when the insulin resistance is at its worst. And there's the biggest separation at that point, showing that having automation really helps to keep the glucose in check. And most importantly, makes it easier for the moms, because every time you see a high number, you feel stressed. So one of the things I like to do in pregnancy clinic is help people anticipate changes. We know that these hormones are going totally nuts over the course of the pregnancy, and it's going to really change your insulin resistance. And across the different trimesters, we have different risks in terms of hypoglycemia and hyperglycemia. But as much as possible, we try to anticipate those changes. One of the things I like to say to women around 24 to 28 weeks is this is when other women would be diagnosed with gestational diabetes. So now you're lucky enough to have two kinds of diabetes. You've got your insulin deficiency, and now you have insulin resistance due to the pregnancy hormones. And so your doses are going to probably quadruple over the next 6 to 8 weeks. But I promise once the baby comes out, the glucose management is going to improve dramatically. We know that as pregnancy progresses, insulin absorption slows down a lot. So we try to focus on increasing the time that people take their insulin before they start to put food in their mouth. And beyond 20 weeks, it can need to be up to 45 minutes. And we really encourage the use of real-time data to help motivate dietary changes. My dietitian and I are like joined at the hip in the pregnancy clinic, and really important not to have carbohydrate restriction during pregnancy, but more of a low glycemic index carbohydrate distribution. So let's go back to this case that I mentioned at the beginning. She's fearful of hypoglycemia. She gets pregnant. Her A1C is 7.4, and she's feeling quite anxious about it. And here's her time and range bars over the first few weeks of 13, 14, and 15 weeks. She's really struggling to get above 50% time in range, between 3.9 and 7.8. And then she gets started on Control IQ as well, which is off-label in pregnancy, but currently we are doing a trial, and I'm a site. The main lead is out in Calgary, Lois Donovan, and really quite dramatically within a week, her time in range improves and continues to be that way across the rest of the pregnancy. And so, a lot of people in a previous time would say, oh, you could never start an insulin pump during pregnancy. But we're starting people on pumps more and more all the time, because the automation, just like I showed you from that study, the IDAP study, is really probably going to be the thing that's going to really make a big dent on, I think CGM did, and I think automation will make a further dent on neonatal complications and just make pregnancy less stressful for these women. So as I mentioned before, once the baby comes out, really once the placenta comes out, you need to be proactively adjusting insulin doses, because the placenta is the bringer of all those bad hormones. And once the placenta is delivered, women become even more insulin sensitive than they were prior to pregnancy. And breast milk is coming in and the pressure's off, the baby's out. So I often say to my moms, I would much rather you be high than low. And then first few weeks postpartum, like we're now targeting a glucose of 8 to 10 rather than 4 to 6, so that we have a buffer zone and you don't have a hypoglycemic episode while you're holding your newborn in the middle of the night. So the third section that we're going to talk about is menopause. So as I was alluding to earlier, premenopause, we have pretty regular cycles. You can see estrogen and progesterone going up and down throughout the cycle. And the other two dotted lines here are the hormones that come from the pituitary gland that trigger the estrogen and progesterone cycling to happen. Perimenopause is when when periods start to become somewhat irregular and unpredictable, and is accompanied with quite a few different negative symptoms, which I'll get into in a moment. And then menopause is truly after you've had a cessation of your menses for 12 months. But you don't need to have a cessation of your menses for 12 months in order to be experiencing troublesome symptoms that make life difficult and make diabetes even more difficult. I'll do that already. So what do we know about menopause specifically in T1D? Not a lot. I mean, the reality is we don't know. There's not enough published literature about menopause in general, and there's much less about menopause in T1D. But it would appear that women who have T1D may enter menopause earlier, especially if they had type 1 diabetes prior to puberty. We know that menopause is associated with a higher risk for osteoporosis and subsequent what we call fragility fractures. And there may be an even higher risk in women with type 1 diabetes. So important to have your baseline bone mineral densities done. It appears that women with T1D may lose muscle strength and muscle mass farther, and of course have a higher risk of cardiovascular disease. So here's another case of a patient who's been living with type 1 diabetes since childhood, having multiple menopause symptoms, irregular periods, night sweats, hot flashes, and weight gain. Overnight fear of hypoglycemia is worsening because her just insulin sensitivity is so unpredictable. And she used to know how to adjust her long-acting insulin in anticipation of menstrual cycle phases, but now that her menstrual cycle has become so unpredictable, she's really struggling and she feels safer running high. She woke up at 2:20 in the morning feeling hot and sweaty, but she left her glucose meter in the kitchen and is too exhausted to get up. Luckily, she has juice close by. What should she do? And so it can be quite difficult to distinguish between the symptoms of menopause and a hypo in the middle of the night. And we know that treatment of a perceived hypo is going to result in quite a rebound hyperglycemia, which is only going to make things worse. And so like another call out for advanced technology, don't leave your glucose meter downstairs, always know where you are, because then you'll know that in fact, this is a menopausal hot flash, which does not need to be treated with juice, but probably an open window, a fan, and a cool shower, and probably some hormone therapy. So what do we know about hormone therapy? So in general, hormone replacement therapy has, it got a bad rap in the early 2000s with the Women's Health Initiative study. And since that time, there has been a growing a body of evidence to suggest that hormone replacement therapy at the menopausal transition for the treatment of symptoms is safe and effective. And too many women probably aren't being offered hormone therapy because of concerns about what came out of that Women's Health Initiative study, which was really a study not done to see about treating symptoms, but done to see if the addition of hormones actually offered longevity and sort of disease prevention benefits, which it doesn't, except maybe for osteoporosis. But that doesn't mean that women shouldn't be treated with HRT. There's not a lot of evidence specifically around whether HRT helps with glycemic variability in type 1 diabetes, but certainly anecdotally there is. You know, one of the hugest things we know that impacts your glucose management is your sleep. And one of the things that women struggle with the most around the perimenopause transition is sleep. And so if you can have a good night's sleep, you could wake up with a glucose that's in range and have an easier to manage day. That in and of itself it feels like enough. And so there are different approaches in terms of getting access to hormone replacement therapy for women with type 1 diabetes at the menopausal transition, because not all endocrinologists are comfortable prescribing it. But hopefully between a family physician and an endocrinologist, you should feel comfortable bringing up the symptoms and talking about the need for hormone replacement therapy, which is safe and recommended for sort of the shortest duration of time at the lowest dose that helps to improve quality of life. So Savannah's going to talk about starting on hormone replacement therapy for symptom improvement, possibly looking at pump therapy as a means of managing variability when it's too hard for her to predict her variability. So what changes after menopause? So in the diabetes, I can't even pronounce this. It's a diabetes perspective follow-up from some of the European countries. They looked at the differences between premenopausal and postmenopausal women, and this was just sort of retrospective review, but they found that women tend to have more insulin sensitivity postmenopause. When all those hormones finally kind of quiet down and go to sleep, they tend to need decreased insulin, especially decreased basal insulin, but not as much decreased bolus insulin. But certainly, I think hypo risk, especially overnight, is a bigger concern. Anecdotally, again, I've seen that my patients need much less basal insulin once they get into their 60s, and we often have very low pump rates overnight, and it's probably has a lot to do with the long-term reduction in estrogen and how that impacts liver glucose. So look at that. I spoke so quickly. Time for lots of questions. So I think my main take-home points today for you is that fluctuating hormones creates varying glycemic responses for people with diabetes across the stages of the menstrual cycle and into the progression of menopause. Um, um, Use of advanced technologies can help with variability, but people with diabetes still need to plan and adjust insulin delivery. And isn't that just the pits? It's such a frustrating thing that even with the best technology we have today, you have to tell it you're going to exercise, you have to tell it you're going to eat, and you likely have to tell it when you're menstruating. And then when you're not sure what's happening with your menstruation, it can become even more difficult. But one of my key messages here tonight is to say that you're not alone and that it's not in your head and that hormonal fluctuations are really impacting your diabetes management. And hopefully you have a responsive care team that you can talk about that with. So I think I'll stop sharing and come back over here and see what's happened in the chat and let Ruth kind of run the show.
So as of right now, we don't have any questions in the chat, but was there anyone in the group that had a question that they wanted to ask? Oh, I've got a question from Andrea. Is HRT recommended even if there are no hot flashes, but just sleep problems?
An excellent question, Andrea, and I think we're all trying to sort that out right now. Traditionally, I was very much taught only give it to people who have like disabling hot flashes happening multiple times a day and they can't function. But I think there's a growing kind of move to trying HRT for some of the more subtle perimenopausal symptoms. One of the biggest challenges is when you add HRT to someone who's still cycling, it can sometimes make things even more difficult. And so some people are actually saying just put people on a low dose pill if they're really sort of struggling. I think that in general, the decision about whether to use HRT is an individualized one, taking risks and benefits into account. But sleep is a big one in terms of even if you're not having hot flashes, there is some evidence that it can help with poor sleep.
And Nicole is asking, how soon before pregnancy should someone start those preconception diabetic targets?
That's a good one too. So I don't think that people need to be hitting greater than 70% time in range of 3.5 to 7.8 before they're pregnant. But I think they need to know about the target. Because I think what happens is if you are like feeling it's so hard to get to 70% between 3.9 and 10, and nobody's kind of let you know that when you show up in the pregnancy clinic, someone's going to tell you, well, your time in range now is actually only 36%. That's rough and hard. So sometimes I'll like play with the Clarity or the Libre view in my office and sort of show people where they're at. But I'm generally happy with being at greater than 70% time in range of the usual time in range target, because that's the equivalent of an A1C of less than of around 7%. And I'm comfortable with that going into pregnancy as long as people are well connected and know to call me right away. Unfortunately, that's not the case for everybody because not everyone's seeing me and not everyone's necessarily having these conversations. So unplanned pregnancies happen all the time. And I think that's when, you'll see the biggest kind of shock factor. But I think what you're getting at is, does the glucose control matter before the fetus or the embryo has even implanted? It doesn't actually. So it's really just like from, a positive pregnancy test that we think the glucose control matters. But the reason we always said you have to have your A1C less than 6% before you get pregnant is because it matters as soon as you're pregnant. So if your A1C is at 9 and then you're pregnant, it's going to be hard to get you into range so quickly. But I hope that long rambling answer gets what you were looking for. And then she also,
Natalie oh, sorry.
go ahead.
I was gonna say Natalie was asking about managing dosage with severe nausea in early pregnancy, especially if you can't eat really. How do you manage your insulin?
Yeah. So first of all, we treat severe nausea and vomiting in pregnancy very seriously. And so I think that that's the first thing, is that you should get on medications to help manage it. Work with the dietitian to look at what foods are triggers and try to find the things that you can manage to eat the best. But obviously we do have patients who will have to post bolus, as they say, because you don't know how much you're going to be able to keep down. And that's just the reality of management. Yeah.
Taylor wants to know, for someone who's eventually planning pregnancy, how much room for error is there? Because it does seem like an intimidating target, and you did get into this in the anxiety around it, but because it's not, and I don't want to say mistakes. I see you say mistakes are bad numbers, and I want to neutralize that, Taylor, because it's not a mistake that you've made, and it's not a bad number. It's just what's going on in your body, and someone like Dr. Halperin is there to help you mitigate some of that, but I'll let you answer that question. I just wanted to take some of the negativity and self-blame out of the question.
Absolutely, Ruth. And I do a lot of that. I feel like I do a lot of sort of positive reframing and mental health counseling in the pregnancy clinic. So before we had CGM, we used to talk about the targets, finger poke targets of a fasting less than 5.3, a 1 hour glucose less than 7.8, and a 2 hour glucose of less than 6.7. And those targets were even harder to achieve because all you have is a point in time. And the reality is that you could be above 7.8 for maybe 20 minutes or 3 hours. But if you only check it once, then you don't know how long you're actually above that target for. And so what I like about CGM is I try to remind my patients is that I'm trying to look at the big picture and not get too stressed about the moment to moment glucose. Because I see lots of women who actually are so anxious that they see high numbers that they take extra insulin and then they go low, and then the variability and the yo-yoing is a really big challenge because they're so anxious about the hyperglycemia. And so you're right, it is a super unfair and really hard target. And I think that similar to just saying that everyone with type 1 diabetes should have an A1C less than 7%, saying that we're aiming for greater than 70% time in range is for every pregnant person with diabetes, for in the tight pregnancy time in range, is also probably unrealistic. But we also don't want to be paternalistic and not share the data. So the data shows the more time you can spend in range, the less likely you'll have complications for your babies. But I have to say that now that I have women using AID in pregnancy clinics, I am consistently seeing a greater than 70% time in range. That doesn't mean that one day you don't have a high blood sugar, because it's not 100% time in range, it's 70% time in range. But I do think it's achievable, especially with our more advanced technologies.
Connor asks what the genetic risk of passing the T1D to the child is.
Yeah, I mean, it's a tough one because it depends a lot on the genes on both sides of the family. But the feeling is that there's the lifetime risk for somebody with one parent with type 1 is around 15%. And so if you're interested in learning more about that and about prevention, I would direct people to TrialNet, which I think has a close relationship with JDRF. There's increasing discussions about screening and prevention because in the US, at least, they've got some things approved. So it's certainly there. But I like to say this isn't your grandparents' diabetes. So I try not to let the fear of passing on T1D be a reason for people to not go ahead and start a family if that's something that they want.
I'm just going to drop the link in the chat. This is how you can access the TrialNet screening. And Haley and Joanne want to know if there's any information about contraceptives in T1D. We have some information on our website about that, but not an enormous amount.
Yeah, so I would say that there's no reason not to use. I'm assuming you're talking about hormonal contraceptives when you say that, because certainly barrier contraceptives are encouraged not just because they prevent pregnancy, but also because they prevent sexually transmitted infections. But I have tons of young adult into their 30s women with type 1 diabetes on OCP. The only real risk is that some people get high blood pressure from their birth control pills, and high blood pressure is a little bit more of a risk in people with long-standing diabetes. But as long as that's being monitored, there's really no concerns. And we strongly encourage people to use regular, reliable contraception until they're ready to have a pregnancy, because an unplanned pregnancy is no fun for anyone, but particularly in type 1 when maybe your glucose management hasn't been as optimal as you would like it to be.
Melissa wants to know, other than PCOS leading from variable ovulation from one cycle to the next, is there any explanation for the insulin sensitivity and the inconsistent increasing and decreasing during the luteal phase from one cycle to the next?
Yeah, so I think every ovulation is a little bit different. So even if you take diabetes out of the mix, some people who ovulate may appreciate that some months they're much more symptomatic in the days leading up to their period, with more breast tenderness, with more low back pain. Other months the period comes out of nowhere and you're like, what? Huh? So I think every corpus luteum, it's just like a live bunch of cells, and it releases different amounts of progesterone. And so I think that's what is kind of getting the explanation that I can give you about why 1 month you might see more insulin resistance and 1 month you might see less. Is that just every month, every ovulation is a little bit different, even when your cycles are quite regular. And then, of course, I didn't get into PCOS at all with this talk, but certainly I think there's an interesting overlay. PCOS is the most common reproductive condition of sort of adult women. And for those who don't know, it's a condition that's poorly named. You don't have to have cysts on your ovaries to have PCOS, but essentially it's insulin resistant phenotype of women. And there's quite a bit of genetic overlap between PCOS and type 2 diabetes. But there's genetic overlap in lots of families between type 1 and 2 diabetes. Probably all of you are listening today know people in your family with both forms of diabetes. And some people with type 1 struggle with insulin resistance regardless, and sometimes a bit related to their insulin have some undesired weight gain. And then we can see some irregularities in the period. And so it's a bit of a vicious cycle. But the treatment approaches can and should be the same. But of course, if you're going to put somebody on metformin to treat PCOS, that is an insulin sensitizing medication traditionally used in type 2 diabetes, then you're going to have to keep an eye on the insulin levels, because the doses might need to be changed. So just like everyone with type 1 is going to go through menopause and should be able to talk about it, I think I try to encourage all of my trainees to always take a menstrual history across like all levels of the lifespan, because whether it's getting a period every month and having fluctuations in your insulin resistance, or maybe you're not getting a period every month and it's becoming increasingly irregular because you're developing some insulin resistant PCOS like phenotype, important to be able to talk about it with your healthcare team.
So, Jordy, I'm not certain we can answer this question. I would recommend speaking to your endo or family doctor, but she's been menopausal since she was 40 and peri in her early 30s, and she's 52 now. Could you still see benefit 12 years post-menopause from HRT?
Yeah, it's a good question. So, sorry, it's 12 years. Yeah. So that's where we start to get. And so I'm going to answer it as in, what does the data show, right? As opposed to what I recommend for Jordy, because we're not going to get into like what kind of symptoms you're experiencing in this talk, but the data from the Women's Health Initiative showed that the longer people were out of menopause and then we added hormones back in, the higher the risk was for some of those adverse outcomes like strokes, blood clots, and breast cancer. And so the goal is to ideally start the hormone therapy earlier, around the time of the menopausal transition. Also things have changed from the Women's Health Initiative in terms of the types of hormones that we're offering women. And so we're doing more transdermal estrogen now, which is probably less risky. The type of progesterone has gone from less synthetic to a more natural type of progesterone. So if there's still a lot of symptoms, it could be worth asking for investigations or a referral to consider it. But with everybody, it's going to be kind of like a risk-benefit discussion, and the risks increase and the benefits decrease the further out you are from losing your periods.
Nicole asks, it's not sure if you can answer if it's even related, but are there additional challenges or difficulties for type 1 when it comes to fertility treatments?
Yeah, so I think that there might be some data that fertility decreases earlier in women with type 1 diabetes, especially those who had it prior to, who got their diabetes prior to puberty. So there's probably something that we haven't quite landed on, don't have enough evidence on, that having hyperglycemia at the time of puberty might impact your long-term egg quality. So it might explain why you have more challenges with fertility earlier and then an earlier menopause. But I don't know of any data that suggests that women with type 1 won't respond to fertility treatments the same as somebody else with the same sort of ovarian reserve. So the challenge might be like if the ovarian reserve, which is a way of saying, you know, what your egg quality is poor, then you may struggle to respond to IVF regardless. But that's the case for many women who don't have type 1 diabetes. So the only thing I would say on top of that is it's really important to work with your team while you're going through fertility. The hormones that they unfortunately kind of have to pump you full to go through an IVF cycle can certainly wreak havoc on your blood sugars because it's almost simulating like a super ovulation. And I've already showed you what ovulation can do to blood sugars. And then, of course, you're spending all of this time, money, energy, emotional investment. The last thing you want is high blood sugars to sort of lead to an increased risk for miscarriage. So nothing to say that women with type 1 can't go through fertility. Many of my patients have, and I've supported them through it, but it's important to be closely linked with your team so that you can keep adjusting your insulin doses around the time of any sort of fertility treatments. And like as soon as that embryo is transferred, you want to be on top of the glucose management.
Gwen is asking if the hysterectomy would lessen the fluctuations throughout the menstrual cycles or menopausal symptoms. And I know there's more than one type of hysterectomy. So
I was just say that, yeah.
That would also depend.
Yeah,
I guess,
so it really depends. So a hysterectomy is the removal of a uterus, but not the ovaries. If you've had a bilateral oophorectomy and hysterectomy, then you essentially are menopausal because if you have no more ovaries, then you've gone from having estrogen to having no estrogen. And many women will experience quite severe hot flashes after a surgical menopause because it's much more abrupt. If it's only the uterus, then the biggest challenge, and that's usually the approach that's taken, is if there's a reason for a hysterectomy related to the uterus, like a terrible fibroid, severe heavy menstrual bleeding, all these gynecological indications for a hysterectomy. Generally speaking, the ovaries are left intact because we know that women having estrogen for as long as possible is important for their long-term health, specifically around their bone health. So if the ovaries are left intact, the biggest challenge that we find is that women don't always know if they are getting to the menopause transition because they don't get periods anymore, because without a uterus you can't get a period. And so that might be a time where actually asking for some blood tests, like checking your FSH, LH, estrogen levels, might be quite reasonable. We don't always require it for everyone because people who have regular menstrual cycles, the history is often enough to know what's going on from a menopause perspective. But in people who don't have a uterus, you might want to get some blood work if you're trying to figure out where you are in that transition. But yeah, so the bottom line is if you have no ovaries, you will have no fluctuations, but you will potentially still have the vasomotor symptoms associated with not having any estrogen, the menopausal symptoms.
Gwen is asking, do you know how early in a female life the estrogen and progesterone start to impact insulin levels? This happened pre-menses?
Yeah, it's a really good question. I mean, I think puberty causes tons of insulin resistance. That's something I definitely know. I said I'm not a pediatric endocrinologist, but I do actually work at diabetes camp every summer. And so I see a lot of preteen and teenage girls. And I mean, the boys too, their insulin requirements can be quite high. So I think there's not just a lot of hormones that play in puberty. It's not just estrogen, progesterone, testosterone. It's also growth hormone, which also makes you insulin resistant, and cortisol. So puberty is a hot mess. Everyone who has a pubertal teenager in their home knows that. And it can certainly impact your insulin levels as well. And in a way, it's almost a bit more like the menopause because it's not as predictable. So, you know, the first couple of years of a menstruating woman's menses are often not regular. And then as you progress to the later teenage years, they become more predictable. It can be tricky, and sometimes the birth control pill is actually quite helpful at just creating a more stable and level environment if all the fluctuations are causing a lot more difficulty with glucose management.
And the question again, this is something to take up with your actual healthcare provider, but if there is any information on having Hashimoto's and T1D in pregnancy, I imagine I think the answer would be yes, but I mean I don't want to say.
No, it's a great question, and I think there's probably lots of people who could benefit from asking the question. So we'll answer it in a general way because we know there's a huge overlap between autoimmune endocrine conditions. So thyroid and type 1 diabetes often go together, and thyroid is really quite relevant to pregnancy. So if you are already taking regular thyroid medication, like Synthroid, levothyroxine, L-troxin, etc., then the general recommendation is that, and I can say this because it's truly in the guidelines, I'm not just recommending it for one person, that as soon as you become pregnant, you need a 40% increase in your dose. And so not all primary care doctors are aware of this, and I have seen this unfortunately get missed at times, but essentially your endocrinologist should know and should be counseling you that I usually tell my patients to take an extra dose on Saturday and Sunday. So if you take 50 micrograms of Synthroid every day, then once you know you're pregnant, you take 100 on Saturday and Sunday and 50 Monday to Friday. And your TSH should be followed closely through pregnancy. And the reason for this is that in somebody who has a functional thyroid, the hormones from the placenta actually make your thyroid make more hormones, because the developing fetus needs thyroid hormone for development. And for the first 20 weeks, it relies on maternal thyroid hormone before it starts to make its own. But if you have an underactive thyroid, then your body may not be able to respond. And that would go even further to say there may be many women with type 1 diabetes who don't have thyroid problems outside of pregnancy, who may actually have mild elevations in their TSH and require treatment during pregnancy and then can come off after pregnancy. And so I always do a routine TSH early in pregnancy for all patients with type 1 because of that close overlap.
Melissa wanted to have some more information about geriatric pregnancies and type 1.
Mm-hmm.
If there are extra considerations for that.
So I would say the extra consideration is that over the age of 35, there's an increased risk for chromosomal abnormalities. And chromosomal abnormalities are because of poor egg quality. And that is not necessarily have anything to do with your type 1. But type 1 in pregnancy, there's a slightly higher risk for malformations and what's the word I'm looking for malformations and miscarriage. And so when you put it all together, it might feel like a higher risk pregnancy. But I would say the average age in my pregnancy clinic these days is like 38 to 40. Everybody says, 30 is the new 40. And so I don't think it's a reason not to conceive. But if you haven't really, if it's something that's really important, one of the things I do sort of generally recommend to patients is if you're on hormonal contraception to come off after the age of 35 just to figure out what's going on, because on hormonal contraception, you have no idea. And after 35, the chance of needing fertility treatments is much higher because egg quality declines. And as to what we were talking about further. So I wouldn't say it's a reason not to get pregnant, but yeah, does it get higher risk the older you get? Yes.
We have about 10 minutes left. If there were any other questions, now's the time to ask them. And not.
Encouraging to know the average age in your clinic. Yeah.
Yeah. So I think that it seems like maybe we don't have any other questions, but yeah, I mean, I also wanted to just echo what Taylor said, because this is, first of all, thank you again for giving a Thursday night to us just before the long weekend. But also, we know this is a topic that is so important and is really hard to find information about. We do have on our website, but I think the opportunity to hear from someone who deals with this day in and day out is, besides all the great information you provided, is very comforting. So, very grateful for you giving us your time tonight and sharing your expertise and answering all of these questions. Oh, we did have one more question. So, I'm going so fast in the chat now. TG is asking, what should I expect in terms of insulin resistance, blood sugar control during peri and post-menopause? Again, that's kind of specific to the individual, but if we can speak on it.
Yeah, well, I think the challenge, I think that what we've probably experienced is in perimenopause, more fluctuations and variability and unpredictable changes in your insulin sensitivity from almost day to day, which is challenging to manage, to say the least. But I do believe strongly that automated insulin delivery will help. The post-menopause, when really the ovaries have finally pooped out and there's no more estrogen, there tends to be an increase in insulin sensitivity overall. So that's what the literature shows us, but individual results will vary.
Also, Andrea and Emma said, so the chance of getting type 1 with one parent is 15%. I just wanted to clarify, it's not a 15% chance. Like, that isn't 15 out of 100 are going to get type 1. Yeah. It's just the chance is 15% more than if you didn't have a parent with type 1. We know that I think it's over 85% of new diagnoses don't have any known risk factors of having a close family member that have it. I don't know if you want to elaborate on that or not.
No, I think it's 100% true, is that most new diagnoses don't come from a relative. But I think that I may have quoted the numbers wrong, but I think that there's the lifetime risk if you have a first degree relative is quite a bit higher than if you don't, but most people don't have. But that's still more new diagnoses are happening without that sort of knowing that you have a first degree relative.
I don't know where Andrea and Emma are, but I hope that clarified that a little bit for you. And okay, I think now I'm just double checking that I haven't missed anything.
Yeah.
Yes. Okay, great. Yes. Okay. I think I got them all. All right. So thank you again so much. This was really exceptionally informative. I learned a lot as well. So I'm very appreciative. I know everyone on this call is as well. And want to wish everybody a really good summer. We'll be back in September. We're talking about disordered eating and type 1 diabetes and some of the challenges around food. So we hope you'll be able to join us for that one as well. And I want to thank you again and wish everybody a really good night and a happy long weekend and a good summer.
Take care. Thanks for having me.